Okay, you're ready. Thank you. Just click on it when you want to search it. The arrow. Sorry.
You guys ready? All ready? All right. I'm Dr. Sadicott. I'm one of the pulmonary critical care guys. So, okay, this is a topic that most people don't really get, interstitial lung disease. I'm going to try to give you just some relatively basic ideas about how you should be thinking about these people. We're going to do like a little bit of an overview so you can figure out what the hell all these things are, all the different IPF, NSIP, sarcoidosis, hypersensitivity pneumonitis. It all sounds like weird names, and why do I need to know this stuff? But you actually, I see a lot of these people in my office, and they don't just magically show up to me. They actually, somebody figures out something's wrong, and then they get sent to me. So you do kind of, it is important to have some idea about how to evaluate some of these people who are short of breath, and it is something wrong with their lungs. And it's not just asthma and COPD, which usually is what everybody gets labeled as. Okay, so the point of this talk is to kind of go over who are the patients who should be evaluated for interstitial lung disease, what are some of the major differences between the different types of ILD, get a little basic idea about what types of therapies are out there, and then what's the prognosis for some of these different conditions. So I like cases. So we start off, 68-year-old guy comes to the office with a 6-month history of worsening shortness of breath and dry cough. So whenever one of these people comes in with these types of complaints, there should be kind of a list when you're trying to get an idea about what's going on, what's the story. These are the things that you should be asking and checking about. So in terms of past medical history, you kind of want to know whether or not have they been, other than just the normal stuff like hypertension, hyperlipidemia, you want to get an idea about what other medical problems they've had, in particular if they've had any history of cancers, malignancies, not just because you're wondering whether or not do they have cancer in their lung, whether it's primary lung or metastatic disease, but a lot of the stuff that we give now for all these different types of cancers, a lot of them have different pulmonary toxicities that are associated with it. So knowing, what they've had before in terms of medical problems, and not just what the diagnosis was, but how they were treated, is really important when you're evaluating somebody in the office for why are they short of breath. Rheumatologic disease is one that, and we'll go through a bunch of them, that can have pulmonary effects also. So knowing that they have a history of lupus, or they have a history of rheumatoid arthritis, or scleroderma, all of those are going to start once you hear it, if you don't ask about it, you're not going to know. But then once you hear it, the hope at the end of all this is that you start to think about, oh, I had this. It could be one of those then. So I'm going to think about that when I'm evaluating them. Social and occupational history, so smoking, we always do that. But things like pets is, always check about pets for somebody who's coming in short of breath. Not just because, do they have cats and dogs and they're allergic, but, the person who has all of a sudden decided to pick up, breeding pigeons. It's out there. We see that every now and then. If you find out that they actually are a farmer and they work out, there's different things that based on what they do, that's going to trigger, well, what is that? Could that be an explanation for why they're short of breath? Whatever their medications are current, and it actually should also be past, right? So if you have somebody who's been difficult to control AFib and has been on amiodarone for the past couple of years, again, you need to, and then they stopped it recently for whatever reason, but they were on it until a month ago, that could still be relevant in terms of your workup of figuring out why they're short of breath. And then family history can always sometimes be helpful also, specifically for any history of malignancy, lung disease, and again, rheumatologic disease. So review of systems. So this is kind of the weirdest part, but when you have somebody who comes in just saying they're short of breath, don't get pigeonholed just thinking that it's a lung problem, right? And so we always talk about, I think that when you first start doing all of this, you think review systems, they're shorter breath. I'm just going to really focus on a pulmonary review systems, and that's kind of it. But that's when you miss stuff, because not everybody is shorter breath just because of a lung problem. And sometimes your review system and figuring out what other things are going on really helps you make a diagnosis for what's actually their problem. So in things to focus on in the ILD world, in terms of skin, rashes, joint pain, skin changes, musculoskeletal edema, myalgias, chest pain, reflux symptoms are a big one, dysarthria, and fevers, chills, weight loss. We had one woman my first year here who was admitted here, who kept on coming in, short of breath, had what looked like some fibrosis at the bottom of her chest. This was her third hospital. Nobody could figure out what was wrong. She had dysphagia. She couldn't swallow properly. And then one day, just randomly, we came in and we saw her, and she looked like somebody overnight had punched her in the face. So she was like black and blue underneath her eyes. So what was her diagnosis? Yeah. She ended up having dermatomyositis. We sent off a CK, it was in the thousands, and then we diagnosed her. So she had dermatomyositis with pulmonary fibrosis. And she's been doing okay on steroids and Rituxan and getting her therapy like that. But that literally we made the diagnosis because we walked in one day and she was black and blue. Like, what happened to you? That's how we know when she flares. She gets black and blue and her son says it's coming back again. She has to get pulse steroids. Exam, it's, again, don't just focus in on the lungs for somebody who's short of breath. All the other stuff that when you examine them will help you to figure out what's going on. So look for strength, lid lag, tongue fasciculations. You have no idea how many people I've diagnosed with ALS in the past 3 years here in the hospital when they come in. Short of breath, I get called for a pulmonary consult, and it's that they have ALS. It's been getting worse for 6 months. They stick out their tongue and it's just wiggling at you. Always cardiac. I love to joke around with the cardiologists that they come in short of breath, and I diagnose people with heart failure all the time. Lungs, rales, bronchi, wheezing, dullness, could be a pleural effusion. Check for ascites, hepatosplenomegaly, feel for lymph nodes. People just don't do it. I've diagnosed plenty of people with lymphoma. Edema, and then skin. Skin's so important for a lot of these interstitial lung diseases and a lot of lung conditions in general. You really want to know if they're having any rashes. Tattoos is a cool one. When I was a resident and fellow, we diagnosed this one person who she had a lion tattoo, and she came in because all of a sudden the tattoo, the mane was raised. So the whole tattoo was becoming raised on her skin. And she was trying to figure out what the hell was going on. Why was that happening? And then, by the way, she had a chest x-ray and she had bilateral hilar adenopathy. Anybody have any idea what she has? She had sarcoidosis. So she had sarcoidosis of the lung and skin. And we biopsied her tattoo and it came back with granulomas with sarcoid. Yeah. So it's a very classic thing with sarcoid, that anything that you can get, if you get skin involvement, the tattoos that people have start to become raised, which is fun. Skin's important. Okay, so the basic workup from a pulmonologist, at least, when you're trying to figure out is there shortness of breath related to their lungs. So it's spirometry. Has somebody gone over PFTs at all with you guys yet? No? I'll do a picture then. And start with the chest x-ray. You don't jump to a CT scan on everybody. Just start with the basic stuff and see. So I do spirometry in the office, so that's not that hard. So spirometry is it's a flow volume loop. You guys have heard of that? Has anybody ever done it just for fun? It's actually not that easy. I always tell people, oh, let's just do an easy breathing test. It's actually kind of hard. My wife is terrible at it. She can't do it. So the whole idea is you take a deep breath in and you blow out all the air out of your chest as fast as you possibly can. So if you have airway obstruction, you can get a lot of air in. But if you have asthma, COPD, you're blowing through a tight, small little tubes. So you're blowing through a straw. It takes a long time to get the air out. So you have this one. So blow out. Takes a long time to get all the air out of your chest. So this is an obstructed flow volume loop. If you have things like interstitial lung disease, right? The lungs are scarred up, they're small. You can't breathe because you can't get that much air in. You have a little flow volume loop. So you're restricted. Don't worry about mix for now. That's okay. So if you see somebody who you do spirometry and they have a restricted physiology, and then let's say you do a chest x-ray. Have you guys had like x-ray? How to look at an x-ray? A little bit. Just basic thing. Like one of my old school pulmonologists was like 80, literally died in his office finally. Did I? That's how we found him. My co-fellow had to code him. Dr. Tierstein. So what he would always say was the way to like get an idea about, you always hear about increased interstitial markings, right? So the easiest way that I used to say to look at it was that put your hand on the x-ray and look beyond that outer third of the x-ray. In a normal chest x-ray, you shouldn't see any white markings. It should be pretty black. So increased interstitial markings, you put your hand there, you still see a lot of white going out to the periphery. That's increased interstitial markings. Okay. So if you have an x-ray with increased markings, reduced spirometry, or restriction on your spirometry, all of those could be consistent with interstitial lung disease. Small lungs, can't get a lot of air in and out. Increased markings, what does that mean? Right? The other possibility for increased interstitial markings, the common one, like CHF, right? Mild pulmonary congestion. The next step should be getting a CAT scan. So most of the patients who come to me, they get an x-ray, it says increased markings, they get started on a little bit of Lasix, it's not getting any better, they get an echo, which looks perfectly fine, and then the cardiologist sends it to me being like, I don't know what's wrong with that. Okay, so interstitial lung disease, it's a diffuse parenchymal lung disease. It's not just one thing though. There's a lot of different conditions that can cause different types of interstitial lung disease with completely different prognosis and completely different therapy.
Sorry, they just can't see it in the when they're. Just ignore it.
Where are they watching?
In the clinic. This is it, right? I don't know.
Okay, so this is my little way of just thinking about it, okay? And I like to think about things, you'll hear me in the ICU say this all the time, I like things to make sense. And so all of these ILDs, it's a spectrum. Everything in our life is a spectrum. So this one is another one where it goes from more inflammatory to more fibrotic. So the more inflammatory is going to be these ones, and I'll talk about what the hell all these abbreviations mean. And more fibrotic is like IPF, the worst. So let's start with IPF. Let's start with the really bad one, and then we'll go from there. So idiopathic pulmonary fibrosis. Have you guys heard about that? Right. So it's idiopathic, therefore we do not know what causes it. There's certain risk factors, smoking, reflux, environmental exposures to some things. We don't really know, right? There is a familial form. It's very uncommon, but there have been certain case reports of people in the family who all keep getting IPF. They found some mutations at like the surfactant proteins and human telomerase. Does anybody know what human telomerase is?
At the end of DNA. Has to do with it like helps with the chromosome when it's far out.
So why do lobsters live longer than us? Yeah, right? Oh my God, that's pretty good. That was like an old school pimp question from when I was in residency. So they found that there's been issues with telomerase in some of those families in the lung. Maybe that's associated with why they get fibrosis. So the bad part with IPF is that If it's real IPF, your median survival is only 3 to 5 years. People have different types of progressions. There's some people, and I have a couple, who remarkably are pretty stable. Most people just slowly get worse over time. Some rapidly just get worse and worse until they die very quickly. A really crappy part with IPF is that people can get what's called these acute exacerbations. So that's the lightning bolt. Which can be, sometimes it can be triggered by an infection, so they get a cold, a pneumonia, and then that infection or episode causes their lung function to deteriorate a lot. And the way I kind of explain this, and I'll get to this in a minute here, is that so the pathophysiology of IPF is that it's very complicated. There's multiple cells that are involved, and the end pathway, though, is that it leads to fibrosis. The thought is, I have a cool picture. Yeah, I see it. So there is epithelial injury that leads to fibroblast activation. There is cells can be brought into the lung, recruited by different cytokines, and all of it ends up being that you activate fibroblasts and start causing fibrosis everywhere. The main thing, the whole concept, and this is how I explain it to my patients and their families, is that there is something wrong with the normal healing process in the lung. And instead of the lung going back to healing normally, it scars. And then if you just kind of think of it like that's what's happening with IPF, it kind of makes sense that somebody gets a bad pneumonia or they get just a viral pneumonia, right? And then they get a lot worse in terms of their fibrosis. Well, it makes sense. They don't heal normally. So they get an infection in the lung. Instead of just healing and going back to being normal lung again, it scars. And that's just, like I said, I like to think about things simply and just have it make sense, because then it sticks in my head forever. That's the problem with IPF. The diagnosis, and it's important in terms of medications. And I don't know if you guys will at any point ever prescribe some of these meds, but if you do and you want to get it authorized and paid for, you have to do some of these things. And the main thing you need to do is you need to exclude anything else that could be causing it, because these medications, as of right now, are only approved for idiopathic pulmonary fibrosis. And the big one is really ruling out any type of rheumatologic conditions, setting off a whole battery of lab tests and kind of showing that they're all negative. But beyond that, you actually don't need to get a biopsy in these patients to make a diagnosis of IPF. You need to have the right pattern on CT scan, rule out everything else, and then you're good. So what is the pattern on CT? So IPF, the classic is that you have what's called basilar honeycomb. So you look down here, you see the upper parts of the lung are pretty well spared. It's going to be peripheral and basilar. That's the honeycomb, this big cysts that are at the bottom of the chest, out in the periphery and more at the bottom. So that's kind of what I said. So you get honeycombing. Traction bronchiectasis is that as the lung tissue, so at the alveolar level, starts to scar down, it pulls apart the airways, right? So it's shrinking there, it pulls the airways, and that's the bronchiectasis that you get. Okay. If you do a biopsy, and this, I don't know if this would ever come on the medicine boards, it definitely comes on the pulmonary boards. The classic thing that will always show up in a board question is that there's something called temporal heterogeneity. And that this is a lung biopsy specimen. This is normal lung, so these nice little thin, small alveoli. And this is fibrotic, so dense, collagen-filled spaces, totally abnormal looking. Okay. You don't need to know what a fibroblast foci looks like. Okay, so for the most part, the only time you really think about doing a surgical lung biopsy is if your imaging isn't consistent, right? So you rule out all the rheumatologic stuff. You always have to do that. But if your CAT scan is not consistent with IPF, so let's say you see a lot of honeycombing at the top of the lung, not really at the bottom, then you have to think about a surgical lung biopsy. But there's a lot of risk, especially in these patients, in doing surgical lung biopsy. It's not just the fact that they already have compromised lungs and you're trying to cut out a piece of their lung. I've seen, in fact, I've had patients who they've just died like after they've tried to get a lung biopsy done. And so this is a tough question, all right? Does anybody know if you do, let's say you do a surgical lung biopsy and you biopsy the right lung, and let's say they get worse afterwards. Which lung gets worse after the surgical lung biopsy? So it's actually the left. And do you know why?
I used to know why.
How do you do a surgical
You're
lung biopsy?
collapsing the right lung to the biopsy,
Mhm.
so you're depending on the left.
So you're depending on the left lung, and usually they get way too much oxygen during the surgery, right? Remember, we always talk about in the ICU, these patients with the ARDS that we're trying to bring their FiO2 down. It's because oxygen can be toxic. It causes free radical formation. And so some of these lung biopsy patients, they go in for a surgical lung biopsy for diagnose their IPF, and they come out of it, and all of a sudden they're much worse. They're more hypoxic, and you repeat their imaging, and their left lung is becoming even more scarred. Our hypothesis is that it's from oxygen toxicity from the biopsy, because it's not the side you did the biopsy, it's the other side. So there's a lot of risk associated with doing the surgical lung biopsy. But sometimes we're just stuck and you have to do it. So like we talked about, like initially, like when I was a resident and fellow, all the medications that we used for IPF were anti-inflammatory, because that's what we thought was the pathophysiology. We thought it was like every other lung problem. You give steroids and anti-inflammatory stuff and it gets better. But we were totally wrong. And now we kind of understand why we were wrong. This Panther trial, prednisone, Imuran, that's azathioprine, and NAC, and acetylcysteine, that was like everybody was on that when I was like a first-year fellow. And then they stopped the study because they realized they were killing people, and we had to stop it on everyone that we were treating. Because now we know it's not an inflammatory problem. True IPF is epithelial injury with incorrect wound healing and scar formation. And so that's what all the new therapies are. And so the two ones that you'll see people on are pirfenidone, Esbriet, and tetanib, OFEV. Those are the two medications, and they really work. All people who get diagnosed with real IPF, you should really think about, do they need to be evaluated for lung transplant? Because we talked about what's their mortality. In 3 to 5 years, most of them are going to be dead, right? So if you think that they could be a lung transplant candidate, I don't care how good they look. You should think about, and you need to try to convince because most of the time you have to convince the patient that I think you should go to this place. Why? I don't feel that bad. I know you don't feel bad right now, but I don't know what's going to happen in the near future. And it's better. The lung transplant process is long. It's really hard to even figure out whether or not you're going to be a candidate. And if you try to do it when you're too sick to be able to walk into the office, you're screwed. You're never going to get it. Steroids, the only time we use steroids really in IPF are when they have an acute exacerbation. Because we have like nothing that really works for that, other than looking for an infection, seeing whether or not you can try to treat that. These patients usually dramatically get worse when they get sick. And you try high doses of steroids and you see whether or not does it help at all. Sometimes it does. If it doesn't, they're screwed. There's nothing you can do if they're not a transplant candidate. So pirfenidone, Esbriet, has been around for a long time. We have no idea how it actually works. It's like a magic drug. You take it, they think it works in a lot of different places and in this fibrosis pathway, but it definitely does work. So the big studies are Capacity and Ascend. In pulmonary literature, this is not cardiology literature. We don't have, it's like pulmonary critical care, like we have really crappy studies, right? Our studies, they're not thousands and thousands of patients. We rarely ever show mortality benefit. We go by 6-minute walk test. Can you just walk a little bit farther with this medication versus without it? That's a good study in the pulmonary world. So yes, these medications they slow down the progression of disease. And this is another thing I tell people all the time. right? We have nothing other than transplanting your lungs to make scarred lung go back to being normal. What these medications are trying to do is to slow down the process of scarring. So pirfenidone, just for, again, like if you're ever actually going to start this on a patient, because both medications work, pirfenidone and OFEV. It's the side effects. I decide based on what side effects the medications have, what patients think they could be able to tolerate. The most common one, all of them have GI upset. There's a photosensitivity rash that people on Esbriet can get. So I had a golfer who wanted to still be able to golf. He was really concerned about the rash, so we went with OFEV for him. Sometimes it's something as simple as that they would go by. OFEV, we actually understand how it works. So it is an intracellular tyrosine kinase inhibitor that works on a bunch of different growth factors. And it inhibits the proliferation of human endothelial cells that get stimulated to make scar. So by inhibiting that, it reduces the scar formation. Their trials, so they had Tomorrow and Impulsus. Both of those studies, they showed that they, again, reduced the rate of decline in forced vital capacity, maybe helped reduce the risk of exacerbations. The big side effects with OFEV is really the diarrhea. That's the biggest one. So people get, literally when you get started on OFEV, the starter pack includes Imodium. And there's a whole process about how you start it. You need to take it with foods. You have to make sure you from one of my patients who was on it, the golfer, he enjoyed the fact that he was told he had to have bacon and eggs every morning in order to take his medication because he was getting diarrhea otherwise. So that was actually great. He liked that. The other things just to think about if you're ever going to start somebody on OFEV is that there is a theoretical, in the studies, there was a slightly increased risk of cardiovascular events with OFEV. It's not been seen with Esbriet. Because of that, sometimes if you have somebody who's had a lot of cardiac disease, you may want to go with Esbriet rather than OFEV. And this is changing now, but it used to be that with OFEV, because it's a tyrosine kinase inhibitor, and it has activity on VEGF, there was a while where transplant centers were kind of nervous about transplanting somebody who was still on OFEV because of that VEGF effect. They were concerned about whether or not would it impair wound healing and have them in the post-op period. And so there was a while when we had somebody who was on OFEV doing really well, needed a lung transplant, was on the list at Pittsburgh, but they made him stop the OFEV as he was getting closer to being on the list. He completely decompensated once he was off and died at Pitt, intubated while waiting for the lung transplant. So I'm still kind of nervous about if I really think somebody is going to be a transplant candidate, they're younger, I think they could be, I may go with Esbriet just in case. It sounds like places now are not as worried about that. They've done enough of them now that they feel more comfortable with just doing it even with the OFEV on, but yeah. You can, you just have to get the authorization. Yeah, it is possible though. Okay, so obviously this is kind of a stupid picture, right? The more short of breath you are, the worse your diffusion capacity is. So diffusion is another one of those tests that we do with a full set of pulmonary function tests. The idea is that it gives you an idea about how well does an oxygen particle from the alveolar sac get into the bloodstream. And so the more crap that's in between the two, the lower your diffusion will be. And so if the space between your alveolar sac and your blood vessel is all scar, your diffusion is much worse. That's what diffusion capacity is. The more you desat, the more honeycombing you have. If you have pulmonary hypertension, the worse you're going to end up doing. And this is kind of what I said. Think about oxygen, start meds, really get them evaluated for a lung transplant early. We see that all the time. The people, they delay, and then they get worse, and then it's too late. It takes too long. You don't have the capacity to be able to do it, and you missed it. Okay, so that's IPF. So the one thing with IPF is that we do have some medications that really do work. It used to be like a death sentence. You knew you were going to die in a couple of years. People live longer now with IPF with these medications. So it's, you want to, once you, because for something, like I said, like these are people who are just going to come in saying, I'm just getting more and more short of breath. Like you can make this diagnosis, send off all these tests, you're going to speed along the process, right? Like when we start saying, oh, we'll refer to pulmonary and wait for them to see him, wait for them to get an appointment, wait for them to get all their tests, it's unnecessary, right? It's not that hard to get a CAT scan. Oh crap, they have what looks like IPF. Send off all those blood tests and you can refer, but then at least everything's already done. And then it's like, oh wow, this guy needs it. Because those couple of months could, depending on which way they are, right? Some are slow, some kind of slow or stable, slow, and some rapidly get worse. That one who rapidly gets worse, by the time they come and see me, they're screwed. Okay, yes. Mm-hmm. I've never heard of that. Yeah. Could be, yeah. But yeah, no, I've never heard of it. I think probably more so for the fact that lung transplant's kind of the worst of the transplants. So it would probably take years for those people to develop real significant scarring again. And only 50% of people post lung transplant are alive after 5 years anyway. So, kind of a crappy transplant. Because it's the one organ that's constantly being exposed to the outside world, right? Every other organ, where do they put the kidney? Deep in the pelvis. So kidney transplants do great. You're hidden down there. You're protected. Lungs, not so much. You're constantly breathing in all the crap that we're all breathing in every day. Okay, so hypersensitivity pneumonitis. Totally different. But it's kind of fun. This is like the house case, right? Somebody who comes in who's short of breath. It only happens when they're in their house or when they're out farming or when they go to their hot tub, right? It's pretty much the easy way to think about it. It's an allergic reaction to something in the environment that they're around. But there's different types. There's acute, there's subacute, and chronic. And they have different, they present a little bit differently. So if you can figure out what it is that they're allergic to, that's the best. Those people do the best. And so this pops up on your medicine boards. Like aspergillus, farmer's lung, hot tub lung with MAI, pigeon breather's lung, remember, proteins and avian droppings, disgusting. Yeah, farmer's lung is the thermoactinomyces. I think that comes up in the medicine boards too, not just pulmonary. But there's different types. So chronic HP, because remember I'm trying to go from scarring to less scarring. So chronic HP is actually, can be very similar to pulmonary fibrosis. It can look a lot like it. And so some differences that if you see somebody with a CT where they say there's honeycombing, these are the patients where you kind of wonder, wait a second, am I missing, is it really IPF or is it something else? Because with chronic HP, so you still have honeycombing, but do you guys see the difference in terms of where it is? So it's in the upper parts of the lung. The bases aren't as bad as it is with IPF. And there's a bit more inflammation and granulomas if you actually did a surgical lung biopsy with chronic HP versus IPF. It kind of makes sense if you think about it, right? Because we're saying that this is an allergic reaction to stuff that people inhale. So kind of, why would it make sense that we're finding more of the fibrosis and parenchymal changes in the upper parts of the lung? Because you're breathing it in. More of it goes to the upper part of the lung rather than the lower part. It's inhaled, right? So that's kind of it fits, right? So you do a CAT scan on somebody and you're seeing fibrosis in the upper parts of the lung. Wait a second, maybe this isn't idiopathic pulmonary fibrosis, even though they're saying that there's honeycombing. If you think about it, could it be something like HP? So these are the one patient, remember when we were talking about fibrosis, where you usually don't think about doing surgical lung biopsies. If you have somebody like this who comes in with shorter breath, who has more upper lobe fibrosis than lower lobe, those people you do think about, well, maybe we need to do a biopsy in this person. Because if you do the biopsy and there's a lot more inflammation and granulomas, then remember, we said there's a spectrum of inflammation to scarring. Scarring, you're kind of screwed. We can't make it go back. But inflammation, how do you treat inflammation? Anti-inflammatories, steroids, all the other crap that we do. But inflammation you can treat. You can make that go back to being normal lung. I can't do anything for scarring to make that normal. So anytime that we can try to figure out whether or not could it actually respond to anti-inflammatory medications is always going to be better for the patient. So even if there's fibrosis, if you think it could be chronic HP, there still may be a role to figuring out whether or not do they need steroids or some other type of actual medicine that can make their lung normal again, somewhat normal. Subacute HP is kind of it's not as obviously acute. These patients, they look different though. So this is what a subacute HP looks like. There's ground glass, there's all these tiny little nodules kind of scattered throughout the lung. They haven't gotten to that part where it's been exposed for years and years and years and they're starting to scar. So they have a lot more inflammation, granulomas if you do a lung biopsy on them. So very different looking. For all of this, we said the best thing to do is if you can figure out what the antigen is and get rid of it. So for people, if they do have hot tubs, clean it, check. So sometimes you can get these companies that actually do all this testing to find out whether or not are there any of these antigens in somebody's house. But because we said that this is more of an inflammatory problem, usually you'll start off with steroids, usually a half mg per kg to a milligram per kg. And you do it for a long time, 4 to 6 weeks, and very slowly taper. If you have trouble kind of tapering these patients, you'll add drugs like Imuran or Cellcept. The data on rituximab is not great, but prognosis for fibrotic chronic HP is much, much better than it is for idiopathic. And these are patients where they may actually do have a benefit from using steroids. So that's where it is important to figure out, is it IPF or could it be chronic HP? Okay. NSIP, now we're going into more inflammatory. So most people don't know what the hell NSIP is when I say it. So it's non-specific interstitial pneumonitis. It can be idiopathic, so it's a pattern, all right? It can be idiopathic, so then it's just called NSIP, or it can be seen with other drug toxicity, hypersensitivity pneumonitis, rheumatologic conditions. And it's all ground glass. Ground glass, not really much in terms of honeycombing. So, all this whiteness. Did anybody have my lady on 5 St. John? Taloka? No? I think she's going to have this, because this is what her CAT scan looked like. But so lots of ground glass, not so much honeycombing, maybe some traction bronchiectasis. That's what we're seeing over here. Yes, yeah, that lady. You saw her CT? Looks just like this.
Yeah.
Yeah. Like whiteness everywhere, coughing, been slowly getting more and more shorter breath for 6 months. I don't think I'm going to make a biopsy on my transbronchial biopsy because she bled like crazy. She's got pulmonary hypertension, but she'll need a surgical lung biopsy. But then I think she's actually going to do probably pretty well. I'll talk about in a second why. So the biopsy will show inflammation with some fibrosis, but not really honeycombing. And it can be more cellular or fibrotic, and cellular, more inflammatory, does better than the more fibrotic version. That's what I was saying. It's all a spectrum between inflammation and scar. This is what the surgical biopsies will look like, and it's much more uniform. Remember I said with IPF, there was temporal heterogeneity. You cut out one part of the lung, one part looks normal, one part looks terrible and scarred and all fibrotic. With NSIP, it all looks just inflamed with a lot of interstitial infiltrate. Usually these patients will do well with steroids. Sometimes you have to use some of those other drugs, like we said, Cellcept, Imuran. And like we said, the more inflammatory stuff is, the better that people do. So, so connective tissue ILD. So you can make a diagnosis of this in a lot of people. So this is all those rheumatologic conditions that can affect the lung also. Because remember, all those rheumatologic conditions are systemic. It's not just going to be a rash, right, or a joint pain. It can affect pretty much any organ in the body. And the lung is a very popular place for all of these things to affect. So dry cough, shorter breath restriction. Most of the time, these patients already have a diagnosis of some type of rheumatologic condition when they come in saying, I'm getting more and more shorter breath. But in 25% in not 25%, but a good number of patients, they'll have nothing. Their first presentation of their rheumatologic condition is that they're getting more and more shorter breath. There is, based on what type of rheumatologic condition that they have, there's different types of interstitial lung disease that they can present with. So, oops. Let's see. The only one that really has an IPF or a UIP pattern, right? So it looks like IPF. Usually it's rheumatoid arthritis. That's the classic one, where you see somebody who looks like they have IPF, an IPF-like pattern, but you do their blood test and it actually shows up that they have rheumatoid arthritis. If you do see, the main thing with rheumatologic ILD is that treating the underlying condition will usually help the lung also. And so instead of just jumping straight to your antifibrotics, like you usually would with somebody who has a UIP-like pattern on their CT, you try treating the rheumatoid arthritis however the rheumatologists want to do it, and some of those patients will get better. As of now, none of the antifibrotic medications are approved for rheumatologic-associated ILD, although it's getting studied. And there are trials, like if you had somebody who had RA or scleroderma who had a lot of fibrosis, they're doing all of these studies in different locations. There's a couple of places in Manhattan that are, I think they finished enrolling patients, but they're doing this because it makes a hell of a lot of sense, right? If you have a fibrosing, whatever is causing your fibrosis, whether it's idiopathic or if it's rheumatologic associated, wouldn't giving you something that slows down the progression of that fibrosis, in theory, make sense, regardless if there's an inflammatory part that you can treat or not. They just have to make sure that it's safe drug interaction-wise. Scleroderma, systemic sclerosis, it's a lot of patients, right? 40 to 80% of those patients can have pulmonary involvement. Usually it's more of an NSIP pattern, although we definitely see more fibrotic changes also. But this one is, there's good data for scleroderma patients that use Cytoxan and Imuran with those patients. So totally different therapy. Again, this is where I was saying you need to figure out why the hell people have their scarring in their lungs before you just throw medications at them. This is the only condition where there's scarring where we use Cytoxan. It actually does help. Anti-SCL70 is something I send all the time, and it's very well associated with ILD. So even if you have a scleroderma patient who doesn't have any ILD yet, if they're SCL70 positive, you need to watch them because they're very likely to develop it in the near future. Let's see, dermatomyositis. So 1/3 to 2/3 of patients will have lung involvement. Their anti-Jo1 is the antibody that's really well associated with fibrosis. And like I said, these are patients where treating with high doses of steroid, like pulse steroids, a gram for a few days, with some of these other medications usually is what gets tried. Sjogren's can sometimes have an NSIP pattern. You can also get lymphoma with Sjogren's. I had one patient with that. The main thing is that it's a different population of patient that walks in saying, I'm getting shorter breath, that you need to think about rheumatologic stuff. So younger women who come in with saying, I'm having 6 months of worsening shortness of breath, those are the ones where you really should think about, let's say you do the PFTs and x-rays and it looks restricted, and those ones you have to really search for a connective tissue or a rheumatologic condition, because they're much more likely than a 70-year-old man who walks in and says, I'm getting 6 months of shortness of breath with restriction and increased markings on x-ray. Okay, so just briefly, I'm just going to talk about a couple of other ILD. There's a ton here. I just wanted to give you an idea about what they are. So sarcoidosis It's this, again, kind of magical condition that nobody really understands it. So it's a multi-system. It can affect anywhere in your body. Granulomatous, non-necrotizing disorder. We have no idea what causes it. It can present anywhere from your 20s to 60s. Half the patients are just diagnosed by accident on chest x-ray because you find out that they have bilateral hilar adenopathy. The main thing with sarcoidosis, which is weird, is that people can have it and not everybody needs to get treated with steroids. It can either be active or inactive. And so if you make a diagnosis of somebody with sarcoidosis, that's great, but then you also have to make a decision about, do I think that they're active or inactive right now? Only active patients need to be treated with steroids. Inactive patients, they don't need anything. So you'll hear sometimes about stages of sarcoidosis. Stages of sarcoidosis is purely a radiologic term. It gives you an idea about what their X-ray and their CT imaging looks like. It has nothing to do about what their disease activity is or how bad is their sarcoidosis. So stage 4 sarcoid just is a representation of what their picture looks like. It doesn't tell you anything. It's not like cancer where your stage 4 lung cancer, it's not good. Stage 4 sarcoid, I've got a 30-something-year-old guy who's got a stage 4 looking image, who's a psychotherapist and he's out and about doing his thing. So stage 1 is just bilateral hilar adenopathy. Stage 2, adenopathy with some changes in the lung. Stage 3, the adenopathy starts to shrink, but you still have the stuff in the chest. And stage 4 is they actually look almost like they have some fibrosis. The biggest thing with sarcoid is that you make the diagnosis by the right history, excluding other stuff, but then you have to have biopsies. Technically speaking, you're supposed to have biopsies from 2 different sites showing non-necrotizing granulomas to make a diagnosis of sarcoidosis. And then you only do therapy in patients who have active disease. So the person who comes in, let's say that if you do a pre-op x-ray and you find bilateral hilar adenopathy. You do the workup, you biopsy something, it comes up with granulomas, but they're completely asymptomatic. They don't need anything. You diagnose that they have sarcoidosis. You found granulomas in those lymph nodes, but they have no symptoms. Their PFTs are fine. They're not short of breath. Okay, just watch them. There's nothing to do. The same person who comes in for workup of 6 months of worsening shortness of breath, who has bilateral hilar adenopathy, maybe some reticular changes on their imaging, who you biopsy and they have granulomas, that person you would treat with steroids. And steroids are like a magic drug for sarcoid. Somebody if it's really sarcoidosis that's making them short of breath, you put them on a mg per kg of steroids and they feel great. They get a lot better. If it doesn't get better with steroids, something's not right. Sarcoidosis always responds to steroids. We used to do this thing at Sinai called the Kavime. It's the weirdest thing ever. It was only at Sinai that you could do this. The Sinai was like a huge sarcoidosis place. So they got like ground up spleen from somebody, I think with sarcoidosis. And then what they would do is they would take a small amount of that and inject it into your skin. And then you would form, if you had sarcoidosis, you would start to get granulomas at that spot. And you'd biopsy the site where you injected the Kavime, and you'd find non-necrotizing granulomas. And that would help you to that was your one spot for making a diagnosis of sarcoid. Only Sinai. I think they still have a little bit of Kavime left, but I don't know how often they actually use it still. Okay, so pneumoconiosis, this is really just for your medical boards, right? Because we're not usually going to see a lot of this. Silicosis is that sandstoner, construction worker, not wearing masks. It can keep getting worse even after they stop working. Simple silicosis is you get these big nodules that over time, it can become, it's crazy looking. These nodules start to almost meld and merge and become these giant mass-like lesions in people's chest. Tuberculosis is much more common. This is a board thing. Tuberculosis in silicosis, you have to watch out for that. It's very common. We don't see that much of that. Coal workers pneumoconiosis. So if you start head down to West Virginia. They see this all the time. It's the coal dust that causes kind of the same thing. These nodules that again can become these conglomerated big black masses. It looks like it can necrose over time. These patients are at a high risk of cancer. So coal workers, cancer, pneumoconiosis, tuberculosis. And then Kaplan syndrome is coal workers' pneumoconiosis that also gets associated with rheumatoid arthritis. Just a stupid thing. And then asbestos-related disease. So asbestos can cause lots of different problems in the lung. So pleural disease, you can see pleural plaques. That's the classic one, at least on pulmonary boards. They show you an image. You have to catch that they have pleural plaques, and then you know it's something asbestos-related. Asbestosis is when you have pulmonary fibrosis, which is due to being exposed to asbestos. That the way you make this one is if you have the same guy who comes in, you do their CT, it looks like IPF, but they have pleural plaques, it's probably asbestosis. It's not idiopathic pulmonary fibrosis. Does that make sense? Because there's no other reason why you have pleural plaques. You had to have been exposed to asbestos at some point. And lung cancer is definitely more common in people who have had asbestos exposure. So our original guy, 68-year-old guy, short of breath for 6 months with a dry cough. He's got no exposures to any of that stuff, no history of cancer, chemotherapy, no rashes, is a non-smoker. This is his CT, typical. All of his lab tests, so ANA, this is the stuff I send off all the time. ANA, SCL70, JO1, myositis panel, Rho, La, that's for Sjogren's, RF and anti-CCP. So anti-CCP is cyclic protein peptide. It's RA. And then I don't need to do anything else. He's got negative lab workup. His CT is consistent with IPF. He's the right story. So I'm going to put him on one of these two drugs and refer him to a transplant center. So the main things to think of, just things to remember, IPF, you see a UIP pattern with fibrosis. The subacute and chronic HP, it's more inflammatory. With connective tissue related ILD, based on what type, it's usually, if it's a UIP pattern, you think rheumatoid, everything else is more likely to be inflammatory and SIP looking. Sarcoidosis, just give steroids only if they're active. Please don't put everybody on steroids forever just because they have sarcoidosis. And then depending on what type of pneumoconiosis you're thinking about, remember silicosis, TB, asbestos coal workers, higher rates of cancer. Okay. That's, oops, hope that was okay to do. Any questions?
Is there a specific radiologic pattern name for hypersensitivity pneumonitis?
No.
It's not like
Yeah.
ILD has used or IPF has used.
Yeah. No. It's ground glass and little nodules everywhere. That's for subacute. Otherwise, it looks more, has a honeycombing pattern, but just more upper lobe. Okay. I actually see a lot of this. There's a lot out there in the community. So, all right, that's it.
Thank you.
Yep.
Thanks. Thank you.
Yeah.
So, I don't know if you remember
The case?
patient